Hi everyone, I'm going to do the diabetes lecture. This is in chapter 47. Don't forget, diabetes is the only representative condition out of this chapter, so make sure you're just focusing on the diabetic content. The PowerPoint is new for me, so hopefully I remember to click when I'm supposed to. Bear with me. All right, diabetes. What is it? It is a chronic metabolic syndrome. The body cannot use carbohydrates correctly. It impairs glucose transport. The body is unable to store and use fats properly. So we have incomplete fat metabolism, which results in ketone bodies in the blood. We have a decrease in protein synthesis with diabetes. The etiology, type 1, is the destruction of insulin-producing beta cells of the pancreas. It's autoimmune or genetic in nature. It arises when a person with a genetic predisposition is exposed to a precipitating event, such as a viral infection. Type 1 is typically what we talk about in peds because it is juvenile in nature. It's usually less than 20 years of age when they are diagnosed with this. Type 1 can occur at any time in childhood, but we do see new cases highest in 2 different times in childhood. Any thoughts as to why these occur? The first occurrence is highest among 5 to 7-year-olds. And what is a stressor for a 5 or 7-year-old? That is when they start school at 5, and then it's as they get a little bit older, school gets a little bit more difficult. So the stress of school, and they're also have increased exposure to infectious diseases. The next group that we see a surgence of and diagnosis of type 1 is 11 to 13-year-olds. And as you can imagine, during that time frame is when they start going through puberty. They have periods of rapid growth, and they have increased emotional stress. We also are seeing a lot of type 2s in our pediatric population. And again, that is attributed to a sedentary lifestyle, poor dietary choices. So with the advancement of technology, kids sitting in front of a screen longer instead of going outside and playing, that's why we're seeing the surgence of type 2 in our pediatric population. Don't forget with type 1, we do have destruction of the insulin-producing beta cells of the pancreas. So they will need to be on insulin because the beta cells are not making that. And then just kind of a refresher too, don't forget about the diagnostics. Glucometer greater than 200 times 2, or we will check a fasting blood sugar once we realize the random is elevated. And don't forget with the fasting blood sugar, we advise them to eat a balanced diet for 3 days, then they're 10 to 12 hours NPO prior to that blood test. And if their result is greater than 126, we can say that they're a diabetic. We've got the 2-hour glucose tolerance test. That is where they are NPO 8 hours prior. They come in and we have them drink a glucose-containing substance. And then we check their blood sugar that way. And again, if it's greater than 200 with that is how we diagnose it. And we're also looking at the hemoglobin A1C. Oh, sorry, I forgot to click. You guys have this anyway at home. Why is it more difficult to manage in childhood? And again, kids are always growing. Various energy expenditures and varying nutritional needs depend on their growth and depend on what activities they are involved in. Early manifestations, the 3 Ps are hallmark. Again, with type 1 polyuria, excessive urination. This can also, when we have polyuria, we'll see our potty trained kids starting to wet the bed. That could be an indicator that they're a diabetic as well. Polydipsia, so excessive thirst, and polyphagia, excessive eating, and then with all of that, they're still losing weight. They'll have glucose in their urine. They'll have signs and symptoms of hyperglycemia, fatigue, and then if we see chronic yeast infections, that's another red flag too. Yeast could be an indicator of diabetes. Our progressive complications, diabetes affects all the systems. Cardiac, it will affect lipid, we'll see lipid disorders, hypertension, metabolic, we worry about hyperglycemia and then going into DKA. Once we treat them, we worry about hypoglycemia, some of the other metabolic things that can come along with our type 1s, hirsutism, polycystic ovary syndrome, menstrual irregularities. We'll see kidneys, we know that's a big one. We'll see albumin or protein in the urine, skin, impaired healing, and acne are issues. And then long-term complications, again, multi-system, eyes, diabetic retinopathy, blurred vision, cardiac, again, you guys know if we don't control hypertension, if we don't control lipids, it will get them into heart disease and peripheral vascular disease. If we aren't controlling our disease and we're not protecting our kidneys, chronic renal failure, we see a lot of our long-term diabetic patients on dialysis. Neuro changes, peripheral neuropathy is the big one. Paresthesias, tickling, tingling, numbness in the extremities. Our immune system, they're at risk for recurrent infections, impaired healing, skin infections, periodontal disease, urinary tract infections, lung infections. So lots and lots of issues with the immune system as the disease progresses. We're going to talk about some different needs of the care of the child with type 1 diabetes. We're going to talk about how do we monitor it. We are going to talk about nutrition, exercise, insulin, self-care, and emotional support. All right, some other things that we want to monitor. We kind of already talked about the some of the blood work that is involved in it. We want to make sure that either the patient or the family knows how to use the glucometer, so they're self-testing at home. We need to teach them the procedure, and we need to teach them how to keep records. Around ages, school age between 6 to 10, they should be able to do their own testing and their own insulin administration, because that's when we see those fine motor skills being able to handle those tasks. You'll see that the glucose goals are not as tight for a younger child due to the decreased ability to self-report symptoms of hypoglycemia. Again, the younger the child, they're not going to be able to tell you, I feel lightheaded, I feel dizzy. So again, we don't have tight as control on that number. You will see anywhere from 70 to 110, 80 to 120 is being the norm. We talked about some of the labs to diagnose. Once they're diagnosed, we typically check their hemoglobin A1C. And if they're less than 6, we like to keep it between 7.5 and 8.5. If they're between the ages of 6 and 12, less than 8%. And if they're between the ages of 13 and 19, less than 7.5%. Again, anything falling in between 6.5 and 8%, we say that they have good control. I believe on 1410 is where they talk about monitoring, and the hemoglobin A1C is in there as well. And you'll see the chart on the bottom of page 1410. We will look at their urine. We look for ketones in the urine. If we do a urine microalbumin test, that actually screens for early renal function, and it can also detect diabetic nephropathy 5 years earlier. So if we're testing their urine for ketones, if we're looking for that microalbumin in the urine, it's a good indicator of their renal failure, or how I should say how their kidneys are functioning. Signs and symptoms of hypoglycemia. Again, we want them to monitor those. Hypoglycemia can be have a rapid onset, shakiness, diaphoresis, anxiety, nervousness, chills, nausea, headache, weakness, confusion, lots and lots of different signs and symptoms. How we treat it is we give them 15 to 20 grams of a fast-acting carb. It can be milk, orange juice, sugar, honey. It's a simple sugar. So make sure we're giving them max. We want it to act fast. We want the body to be able to break it down quickly and utilize those carbs. After we give that, we recheck the sugar. If it's still low, we will give an additional 15 to 20 grams more of a fast-acting carbohydrate. We check the blood sugar again. We typically wait 15 minutes, staying with the patient, monitoring them to make sure we shouldn't be checking it any sooner than that. If we get a normal reading, we would follow that up with a protein, a complex carb, cheese, peanut butter. Make sure you're checking for any allergies before we give them something. If the child can't swallow, if the child becomes unconscious, we can give subcutaneous or IM glucagon. If they're in the hospital, we can do IV push meds to get that blood sugar raised as well. Hyperglycemia, we see some different signs and symptoms, gradual onset, hot, dry skin, fruity breath. Again, the fruity breath and the Kussmaul's respirations. You're worried about them getting into DKA with that. The treatment for hyperglycemia, we would give insulin, oral fluids, and make sure we're testing the urine for ketones. We're talking about monitoring blood sugar still, and another good rule of thumb is they should monitor their blood sugar every 3 to 4 hours when they're sick, and they should test their urine for ketones. The urine should be negative to a very small amount. If it's not negative, or if we're not seeing small amounts, it should be reported. Don't forget, ketones are when fats are being broken down as used as energy. So that's what we'll see. And again, we're telling them when they're at home and they're sick to monitor their blood glucose every 3 to 4 hours. They can monitor it more often if they feel that they are symptomatic or their symptoms are changing. We need to make sure that we give them some good guidelines when to call the doctor with their blood glucose. We typically say a blood glucose greater than 240, call the doc. I'm sure every pediatric endocrinologist would have maybe a different guideline, but that's what we'll say for our lecture is call the doctor if your blood glucose is greater than 240. If they have a fever 102 or higher and it's not responding to Tylenol, or if it's lasting more than 12 hours, we want them to call their doctor as well with that.